Looking for the perfect pre-carnival fete? Then get ready for Rhythm and Spice, a Rotary brunch experience happening Sunday, June 28th from 3 p.m. to 11 p.m. at Quarantine Point Recreational Park. Enjoy an afternoon of bold flavors, vibrant rhythms, and unforgettable vibes featuring Sakina and the Alpha One Band, plus guest artists and DJs. Early bird tickets are just $200 and available now on GoToFet.com. Dress code brunch chic, island elegance with spice-inspired tones. Hosted by the Rotary Club of Grenada. Proceeds support Rotary Community Projects. Rhythm and Spice, Sunday, June 28th, Quarantine Point Recreational Park. Sip, savor, socialize, support.
Drug abuse, cancer,
measles, diabetes, AIDS, cancer,
drug abuse.
Kids Planet, located at number 3 NIS Complex, specializes in everything for your children from newly born and upward. At Kids Planet, you will find clothing, school bags, hair accessories, sandals, shoes, strollers, car seats, bathtubs, baby bags, swings, walkers, playpens, and many more. So what are you waiting for? Hurry on down to Kids Planet and find what you have been looking for. Or call them on 444-3996 or 533-3996.
Asian Spa and Wellness Cafe, nestled in the serene surroundings of Le Phare Bleu, Calivini Bay, St. George, is the perfect spot to unwind and relax after a stressful event or when you wish to spoil yourself in the most comfortable and relaxing atmosphere. They offer many different massage modalities, including thigh hammer, washer and cupping, signature thigh deep tissue massage, also facials to depuff and tighten pores, deep cleanse full body, hair and nail treatments and more. Take a walk down to the cafe for authentic Thai breakfasts and delicious traditional dishes. Choose from our special mixed drinks, both hot and cold. Opens daily. Visit Asian Spa and Wellness Cafe today, Le Phare Bleu, Calivini Bay, St. George, because you will not regret you did.
Drug abuse, cancer,
measles.
Good evening once again and welcome to another Doctor on Call. It is a pleasure as always. Yes, of course, every Tuesday evening at 8:30 we bring you information and we share with you that can help you to improve your wellness. Of course, as always, Dr. Nixon is with me, and we do have a very special guest joining us as well. Not a stranger to the program, but it's been a while and probably long overdue. So in a moment, you'll get to hear from her. But before we get into it, of course, we welcome all our viewers on GBN Television, 711, our friends on our Facebook page and YouTube channel, and also to you, our listeners on K105 FM. Tonight, we're talking sickle cells. And in fact, tonight, I think Dr. Nixon is going to host, and I'll just be the backup. Yeah, I think that sounds like a good plan, yeah? So, Doc, good evening. How are you doing?
I'm happy because it's raining.
It is raining.
I'm always happy when the rain falling.
Yes. So, well,
really very happy.
Considering the hot spells we had recently, I think the showers are more than welcome. So I'm quite happy as well. But Doc, we have a very special guest with us. She's not a stranger to the program. She's been here before, but I think we should be having a little more often. So we have to. Yeah, we have to work on that. You know, we need to have a direct contact. So we just press a button and she pops up on the screen to chat with us. So Doc, I'll tell you what, I'm going to allow you the opportunity to introduce her, and then we'll get into our discussion for this evening.
So again, good evening, everyone. Good evening, Grenada, the diaspora who will soon be coming home for the party, and everybody else. Thank you for joining us, especially our old faithfuls, all my seniors who buck me up in tongue and say, "Doctor," if I talk. And anyway, it's really nice having everybody on tonight. I want to welcome my young colleagues, very special young woman, Dr. Anika Clouden. I'm going to stop there, and then I'm going to add James. Well-known family in Grenada, family in service in Grenada. And it's really a pleasure to have her with us tonight. I want to say, first of all, that Anika has just become the chairperson of the Sickle Cell Association of Grenada. She's done a little work, so we're rewarding her with more work. Okay? She's young, she's enthusiastic, she's talented, she's vibrant, she's selfless, she's willing to serve in the community. And so I want to personally welcome her on this platform and thank her for agreeing to serve, because I dug that, okay? I have too many other things doing, right? And before, though, I want to thank Mrs. Ann David Antoine, who for the last decade or so has led the Sickle Cell Association to the formidable state it has acquired, it has achieved, okay? She's worked, she's pushed, she's advocated. And the last big thing was recognizing Walter Clement Noel, which we can talk about later, who was the first patient with sickle cell. So we want to thank her. We want to thank her for her service, and above all, thank her for the fact that she has actually agreed to be. I'm here if you need me, all right? With all the experience she has and all the links that she's established, there's never enough time to give all the information that she probably guards within herself. And so we thank her very much for having held the hand of the Sickle Cell Association today. So Dr. James is a current pediatric, that means child hematology oncology, blood cancer fellow at the Children's Hospital in Ohio. She said she's from Perlmutter in St. David's. And of course, she went to the school, St. Joseph's Convent in St. George's. And then she went to do a associate degree in natural sciences at TMI Show Community College. She did her undergraduate study at SGU, earning a bachelor's degree in biology and then a master of public health, which is always great when you want to practice medicine. And then went to medical school at SGU, from where she graduated in 2019. She completed a medical internship and worked as a pediatric house officer at the Grenada General Hospital. In 2021, she migrated to the U.S. to begin her pediatric residency training at Southern Illinois University. She's now a board-certified pediatrician, so we have one more coming, but she's also doing a fellowship in pediatric hematology and oncology, that is diseases of the blood and cancer in children. So we're going to be really blessed when she comes back, which is soon. But tonight we're happy to have her here. So Anika, welcome home for this short time. I know you've been involved in research at the hospital. And again, thank you for taking up this position to lead the Sickle Cell Association. You got us behind you. Right behind you, in front, okay? So thank you.
Thank you so much.
So tonight we want to look at sickle cell. This is sickle cell. It's a sickle cell World Sickle Cell Week. We do a week, but there's World Sickle Cell Day on February 19. And am I in February still?
June 19.
On June 19. Okay. Every time you celebrate a day, is a day to inject a little more oomph into whatever you've been working with, to raise greater awareness and to hope that more people become converts in understanding what the condition, whatever the cause is. Here, sickle cell, where 1 in 15 persons in our population carries the gene. That's just a sickle cell gene. Not everybody has sickle cell disease, but we have a substantial amount of people with sickle cell disease, and doctor's going to talk about that in a while, with sickle cell disease and the challenges it brings. And I want you to also talk tonight, Dr. Clouden James, about the cousins of sickle cell, because sometimes we forget that they're there and they add a lot of complications and a lot of doubt as to what exactly are we dealing with. And since you're going to come back and look at that and take care of that when you get back, but I want you to talk about sickle cell. So I'm gonna give you the floor. We're gonna ask you questions, but let's talk about Sickle Cell Awareness Week first of all, because I know there's a series of events, and then we're going to talk short about sickle cell and other things that that are related to that.
Thank you so much, Dr. Nixon. It's a pleasure to be back here again. I know it's been a while. Seems like I'm dropping in like yearly, but Sickle Cell Disease Association of Grenada, we are celebrating Sickle Cell Week, as Dr. Nixon said. So we have a week of activity to raise awareness and advocate for our patients and families living with sickle cell disease in Grenada, Carriacou, and Petit Martinique. We started on Sunday with a church service. We always start with a church service. So we had a church service at Petmata Gospel Hall on Sunday to kick off the week of celebrations. Tomorrow, Wednesday, 17th June, we're having an island-wide motorcade. So we're going to start at the association's office on the Carani James Boulevard. And then we will go up on the eastern side, go through all the parishes. We're going to stop at different places along the way, giving out information, raising awareness, talking about sickle cell disease. We're coming to meet everyone where they're at. Then we're going to go to St. Patrick's at the RC Cemetery, where Sir Walter Clement, as Dr. Nixon alluded to, was buried. He was the first patient or person in which sickle cell was discovered, and he's Grenadian. So we're going to lay some flowers at his grave, just in commemoration of World Sickle Cell Week. And then we're going to come back down on the western side, stopping off again at different points in every parish, just continuing to raise awareness. Friday, so that's all tomorrow, Wednesday. On Friday, it's World Sickle Cell Day, so June 19th. So across the world, everyone is celebrating, raising awareness of sickle cell. We're doing Shine the Light on Sickle Cell Disease on that day. We encourage everyone to wear red ribbon, business places if they can, light up your business and your buildings red, just raising awareness of sickle cell, World Sickle Cell Day. And then also in Carriacou, we're having the members of the Sickle Cell Association there are having an event at 5:30. There'll be a guest speaker and just celebrating and raising more awareness of sickle cell disease. So this is our week of activity, kicking off to just celebrate, raise awareness, empower, do some education on sickle cell disease.
Right.
Thank you.
Doc, I want to ask a question because this is not the first time we've spoken of sickle cell. We've talked about it, from time to time, and it's important. But every time we talk about it, Walter Clement, that name always comes up, and I understand that he was the first patient. But there seemed to be something about him always been mentioned. And sickle cell is something that it's a lifelong condition. We know that it has taken the lives of a lot of people. But why is it so important that Mr. Clement's name comes up, and it doesn't just come up as the first patient, but there seemed to be something much deeper than that attached to his name. What about it?
So he was a Grenadian. He was a dentist. He immigrated from Grenada to Chicago and was studying dentistry there, and had lots of symptoms that patients with sickle cell have. So having pain, having lung infections, and complications while he was undergoing his studies. He completed his studies, but while there, he was hospitalized many times. Doctors was intrigued by his condition and his symptoms. And because of experiments basically that was done on him, sickle cell disease was discovered. So his name forever goes down in history as the person in which sickle cell disease is discovered. And the fact that he's Grenadian, I think that's just very important to us here in Grenada, that a Grenadian, you know, we're just such a small island, can have such a big impact in the world in discovering this disease that affects millions of people across the globe.
So there are two other things. One, that this is the early 1900s, because he came back in 1906. Yeah,
1910, I think. Yeah, 1906, but 1910 was
in 1960. Right. So hear me now. In those days, we never had any rules that governed research. Today, if you wanted to do, if you wanted to figure out who are the children at convent with sickle cell, we had to go to the
IRB
the board, right?
Yeah.
Who give us permission, but we have to prove that this is going to be as humane and confidential, and there's no harm caused, and we can't use children who live in homes. We can't unable to use seniors. We're unable to use people who cannot sign for themselves. We unable to use people who are incarcerated. Those are rules that were created after. So I always wonder, what was Walter Clement Noel subjected to as a person who became the object of research when there were no guidelines, when there were ethical guidelines? Right, and that's one of the things I think we take seriously into consideration. Here is somebody who would have been a subject of research, the very first person to be recognized with this strange disease. And luckily, they didn't have a lot of the details that we have today, so they used a microscope to look at cells. And that's how they discovered this red blood cell looked different from what red blood cells normally look like. What's going on here? Okay, but the very fact that he became a subject of research in a time when Black people were not necessarily considered of any much value, and in a time when we didn't have guidelines, okay? So that's very important, right? The other thing is that the very fact that he was the first subject of research, there were millions of other people who subsequently, having the same symptoms, having the demographics as per your origin, because we know that sickle cell is very prevalent in people of darker skin, okay? Particularly the African continent, but not only limited to the African continent. Let's remember that. So there have been so much research after, but not just research and figure out who has sickle cell. How is this disease? How does it come about? How do people respond? What medication? How do they respond to therapies that we have developed? So, as a pioneer, he may not have had a lot because he came home and lasted, 6 years? If so long, right? And passed. He died in 1916, right? 1916, yes, 110 years ago, right? But as a pioneer, we really recognize him, because maybe if he was not diagnosed that day, somebody else would have been, but thank God it was him, so we have that to claim. But at the same time, he opened the pathway, his voluntarism, because I guess he had to volunteer, go to the doctor. You don't sign any paper, say, okay, take my blood. Can I have some more blood? Take some more blood, okay? Because he also had a leg ulcer, which is what he had when he landed in Massachusetts on his boat, right? But coming from Grenada, well, he went from Barbados, actually, to Massachusetts. The truth is, just being a subject and then being a subject that motivates further research, right? At least 9 million people's lives have been saved in the world, okay? People who would not have known what has happened, who may not have developed medications, or just the general hygiene practices, making sure they have enough oxygen, the diet, the nutrition, the hydration, and all the stuff, right? here we have somebody who opens the way. And I think that is what is so commendable about Walter Clement Noel.
Okay, wonderful indeed. So let's start talking about the actual condition itself. What it is. How does one become a patient of sickle cell, so to speak? What actually happens to them, and why is it a condition that stays with them throughout their life?
Okay. So good question. So sickle cell disease is an inherited disease, which means that you're born with it. You get it from your parents. To have sickle cell disease, you have to have 2 copies of the gene that gives you sickle cell disease. So you get 1 copy from your mom, 1 copy from your dad. So everyone that has sickle cell disease, no matter at what age that they became aware of it, they've had it since they were born. It is a chronic condition. It stays with you for the rest of your life. What happens? So normal hemoglobin, or your red blood cells, that's the cells that carries oxygen and gives you energy. Oxygen to all the organs and parts of your body. It's normally round. In sickle cell disease, it's sickle, like a sickle or a C or a crescent moon shape. So what happens there, the wrong red blood cells are able to pass freely through your veins and your arteries and flow nicely. But patients that have sickle cell, because the blood cells are shaped like a sickle or a C, they're sticky, they get caught, they get stuck, and causes the complications of sickle cell disease. So the complications of sickle cell disease, as you know, blood goes everywhere, so it can affect every organ in your body, but it's mainly characterized or mainly shows up as very painful crises. So pain in anywhere in your body, could be your joints, your back, your chest, your belly. So you can have pain anywhere. You can have other symptoms. So as I said, these blood cells are sticky, they get stuck. So you can have strokes, you can have problems with your eyes, it can damage your heart, it can damage your lungs, your kidneys. You can have ulcers because your blood vessels, the blood in the vessels are not flowing well. So it can affect nearly every organ. Not every patient would have the same symptoms. It differs from patient to patient what symptoms show up and how bad they are or how manageable they are. Sickle cell disease, as I said, is inherited. So you get 1 copy from your mom, 1 copy from your dad. So the people that have the copies and not the full sickle cell disease are we say they have sickle cell trait. So patients with sickle cell trait have no symptoms. They live normal, healthy lives. So that is why we at the Sickle Cell Association encourage people to get tested, to know your sickle cell trait status, because that is what determines if you can have a child with sickle cell disease. So knowing what your sickle cell trait status is important for family planning, basically. And to know the probability, it's a 25% chance that your child can have sickle cell disease if you have a child with someone that also has a sickle cell trait. There are other traits that you can have that can have combination with sickle cell disease. So sickle cell disease is an S. You can have a C trait, and you can have some other blood disorders like thalassemia. So if you have a trait of that and someone has a trait of sickle cell, you can come together to have sickle cell thalassemia. So there are different combinations, but getting tested, knowing what your sickle cell trait status is important for that reason.
All right. So another question, and either of you can take it. A patient comes to you, not feeling well. All right. Maybe some pains, whatever. And Dr. James, you did say that the symptoms vary in people. It may not be the same. Different people may have different symptoms. But what would sort of spur the physician to look in that direction? Because there are thousands of things a doctor can look for in coming up with a diagnosis, as it relates to a patient feeling unwell. What would spur a doctor or a physician in that direction? Let's say apart from knowing that person's family history.
Okay. So apart from family history, some of the classic signs of sickle cell disease, the patients will have anemia. So anemia is low blood when your hemoglobin level is low. So you have less energy, more tired. Sometimes we call it pallor, so you look pale. Mm-hmm. And then with sickle cell disease, if you said the person comes with a painful crisis, when that happens, having pain, your red blood cells are breaking down faster than they should, and sometimes your eyes can be yellow, your skin can be yellow. So there are different signs that we look for, and then normally when you have all these symptoms together and you do a blood test, you would see anemia, and you can see signs of sickle cell disease breakdown on some blood tests as well.
Okay.
So one of the things that make the difference as well is the fact that since we know that 1 in 15 person carries the genes, and we know that there's a significant population that actually suffers from sickle cell disease, you kind of need to have that index of suspicion. Here's a child who keeps on having anemia, who has pains, who fails to thrive. They don't grow as well as their peers, or they have longer bones, who have chest pains, who might have chest colds, or have, you might see ulcers forming. And sometimes you just really have to have an index of suspicion. Can this be? And sometimes when you ask mother, anybody have sickle cell? I hear they say somebody had. Or they said I had when I was pregnant, right? So a lot of people think that after you're pregnant, it goes away. No, it doesn't. It's just there, right? Because sickle cell is one of the things that we also screen for in pregnant women in Grenada. If you found with sickle cell, even traits, right? You to ask a partner, the expected father of the child, of the fetus that you're carrying, to have himself tested, because you kind of need to figure out what happens at birth. Luckily for us now, we screen at birth. Okay, we screen our children through one of our partners in Martinique. We had a screening program, and which has been reinstated, right? Yeah. And so our children are screened. But the truth is, older children who probably over 12, you may want to get them tested, because you have to carry always that index of suspicion. Once the child is always tired, doesn't grow, have poor appetite. Yeah. And like doctor says, the truth is, the jaundice will tell you, because in children with full-blown sickle cell, in people with full-blown, whereas our red blood cells break down once every 90 to 120 days in ordinary people. In the case of people with sickle cell, up to every 30 days. So you have a rapid turnover. If your nutrition is poor, you not only will the breakdown of the red cells bother you, also the fact that if you don't have good nutrition, it's going to take a little time before you make back new cells. So the anemia, the lack of the low red blood cells and low hemoglobin, which carries the oxygen, is predominant as a feature.
Okay. In sort of doing a little research for the program, one of the things I came across had to do with swollen hands and feet. But, there are numerous things that can cause your hand and feet to swell. So again, what about that? Will that come about with other symptoms to sort of direct the physician along that line?
So the swollen hands and feet primarily, so most commonly, can happen at any age, but most commonly happens in the babies because their hands and their feet are smaller. So the blood gets stuck basically, and you get swelling and inflammation and you get pain. So the babies would be crying and having pain and having swollen hands and feet. So that's a early sign of a sickle cell crisis in babies. So that's something we do look for. If, as Dr. Nixon was saying, having an index of suspicion, if you're seeing a baby or a young child, a toddler with crying and pain, having swollen hands and feet, they probably are going to look a little pale, a little jaundice, the yellowing of their eyes. That's something that we'll be suspicious of and we'll test for.
Okay, lovely. What about, there was something else I saw, right? Delayed growth or puberty. Let's talk a little bit about that.
So as Dr. Nixon was alluding to that a little while as well. So it's the same thing. So your blood is what carries your oxygen and carries your nutrients to all parts of your body. And that's what your body needs to grow. So patients that have sickle cell disease, again, not all, but some of them, if they're having lots of painful crises or lots of sickle cell episodes, not getting enough oxygen and nutrients to all the parts of their body, you can have delayed growth. The new term now, instead of failure to thrive, is growth faltering. So you can have growth faltering, not, you can, if they have siblings, you notice they might be smaller than their brothers and sisters. And just, so that's why nutrition, hydration, eating a well-balanced diet is very important for all people, but definitely patients or people that have sickle cell disease.
Okay, excellent.
Speak to the lengthening of the bones as a compensation.
So when your body is not getting the amount of oxygen it needs, your body is trying to push out more red blood cells. As Dr. Nixon said, normally when you're with patients that do not have sickle cell, your blood cells turn over every 90 to 120 days. Patients with sickle cell, their blood cells are turning over every 30 days. So instead of 3 months, 1 month. So your red blood cells are made in your long bones, so your hip bones, in younger babies, your frontal bones, the bones of your head, your arms. So your body's trying to push out these cells faster, so you can see frontal bossing in some patients that have diseases of hemoglobins as well, as your body's trying to compensate.
Trying to make more cells.
Right, and lastly, in terms of symptoms, how's one's vision affected by sickle cell?
So it's called sickle cell retinopathy, a big fancy word to say that it affects your eyes, and that retina is what brings nutrients and blood and stuff to the eye. They help you to see. So if the same thing, your blood cells are shaped in a C instead of wrong, they get stuck. And numerous times when you're having these crises, your blood gets stuck there, then there's scarring, so oxygen and blood and everything is not going where it's supposed to, so you can have trouble with your vision, losing your vision there. It's not a very common side effect, but it is common enough that it's recommended that once a year after age 10, patient gets seen by an eye doctor who has sickle cell disease, looking at the back of their eye to monitor that potential for vision loss.
Right. So Dr. Nixon, let me come to you now. We know that there was a time when people who had that condition did not live very long, maybe into the 30s, maybe 40s, and after that we lose them. I know of people now with that condition who are well into their 70s. What has changed since?
Well, knowledge. Thanks to Walter Clement Noel as patient zero, right? So what's more, research is what leads us to make decisions for managing people with disease conditions. You have to understand, right? And research is what gives us objective information, evidence as X, Y, Z, okay? But apart from that, so research and spreading the knowledge, because if I let's say we're in Chicago, let's say you're in Ohio, in some little state where everybody, very few people look like you probably wouldn't expect it to happen, right? You probably wouldn't expect it. And there are a lot of people, a lot of doctors who kind of don't really. However, it is something that is taught in medical school, wherever. And especially when you go into areas where the possibilities are higher, depending on the demographics. So I tell my medical students when I do clinical skills, when you go into a town, you cannot figure out what's going on there. Learn the language, and I mean be able to speak Grenada when you come to Grenada. Know what is oil down when you're living in Grenada, right? Know what is, when you say you have operation, get accustomed, but also learn what are the diseases that predominate in the environment. So again, there'll be that index of suspicion. But then we have protocols as to how to manage with how do we care for, what do we advise them, what medications they will take. So for example, you talk about dying young. Yes, and they died young because they had pneumonias. They had chest sequestration, where you have all these cells clogging up the chest, right? And people who have chest syndrome will most likely die unless you identify it early. Okay? They can die unless you identify it early. And some parents say, oh, the child just have a little cold, that will go away, right? While the child is hyperventilating, the mass in his chest that really creates a lot of pain when he breathes. Okay? There's a mass in his chest where all his red blood cells are being held together, so he has anemia anyway, right? So knowledge is what. The other things that we screen, like I said, in our environment and in environments where you have a high incidence, a high number of new patients, right, and a high prevalence, which is what already exists in the community, we screen. You look for it, okay, and we know what are the nutritional pathways we should encourage our patients to practice. So I don't want that my sickle cell son eating Marie biscuit and drinking soda. That is not nutrition. Another child might get away with that a little more, but this child needs to be building up red blood cells. My child with sickle cell needs to be building up red blood cells every 30 days. He needs to have his proteins. He needs to have his green vegetables. Okay, he knows that his cells are not going to be as fluid because they're not like mine, that nice and round and flow through my organs and flow through all the little spaces in my body. His cells, they're hard. They're shaped like a C. Like a sickle, the thing you use to cut wheat, right? And also they stick together. They love sticking together. Okay, so that agglutination will cause blockages of the artery of the things, and he will know that if he doesn't eat as he should, he's going to have another crisis. Does he want to have that? No, he doesn't. Okay, mothers also and fathers, parents need to understand that. Dr. Clouden spoke about eye retinopathy, but you can have strokes. Because those same little broken abnormal red blood cells would go jam up together and go into your brain, into little vessels in your brain, and cause you to have strokes. And it can happen in your child. Mm-hmm. So now we know. So there are medications we give. To prevent pneumonias, they get a pneumococcal vaccine every year. There is medication like hydroxyurea, which is relatively new compared to a lot of medication that they are given as preventative, as prophylaxis, right? That is provided for them. And of course, we have clinics that all children attend. So from your diagnosis, you screen at birth and there's a suspicion, and at 6 months is when you will definitely know whether you have sickle cell disease or not. And you pass on to the clinic. There's a pediatric clinic and there's an adult clinic, right? And of course, like I said, if we can give the patients the advice and support them in living the lifestyle that they require, they would live longer.
So, Doc, you mentioned, these cells can go to your brain, come together, and you can cause a stroke. All right. Dr. James, what are some of the other complications associated with sickle cell that we probably need to know, and maybe some that are probably even more prevalent than others that we should definitely pay attention to?
So, as you said, stroke, we talked about eye disease. So one that's really common and happens to everyone that has sickle cell disease is splenic infarction. So that's a big fancy word. So your spleen is the organ on your body that filters a lot of your blood. So we said these cells are sticky. So they're sticky and sticking into this spleen that is filtering blood. But what your spleen also does, it helps you fight some infections. Some infections that are harder to treat, your spleen helps your body take care of that. So patients with sickle cell disease has decreased immune system. They're easier to get serious bacterial and fungal infections. So because of that, all babies, as soon as they're diagnosed, are started on antibiotics that they have to take daily from 0 to 5 years. Up until they're 5 years, they take these antibiotics daily because of the sickle cells sticking in the spleen, making that spleen not work. They're increased risk of infections. Other complications, it can affect your kidneys as well. So your kidney filters, your body produces urine, blood goes through there a lot. So you can have sickle cell nephropathy. Nephropathy means affecting the kidneys, so you can have disease of the kidneys. The most other very common complications is the pain crisis. So you can have pain anywhere. So especially when you don't stay hydrated, so not drinking a lot of water, extremes of weathers. So if it's really cold or really hot, it causes the cells, those blood cells, to stick together. They can stick in your back, in your legs, in your arms, in your chest, having lots of pain. Dr. Nixon talked about acute chest syndrome. So that is when those cells get stuck in your lungs and can cause pneumonia. So you're getting an infection on top of that. And that it's a very serious complication that needs to be treated right away. So a child that without sickle cell disease having a cold, depending on what it is, can be mild and managed at home. But a patient with sickle cell disease, like having a cold, can lead to acute chest syndrome and other serious complications. So as I said, it can affect all your entire body in different ways. Not because it can affect you that way, that means every patient with sickle cell disease will have these complications, but it's something to be mindful of. And when you're mindful and you know that these complications can happen, you can look out for them at the first sign, so you can get attention, seek medical advice, medical interventions, take medication for them as soon as possible.
Okay.
So the way for us to get kidney problems, remember, when we have acute dehydration, and that can cause acute renal failure, acute kidney failure, because of all the red blood cells breaking on the higher hemoglobin and free hemoglobin that's circulating in the blood, and the kidney is not able to deal with all those toxins. Plus, if you lose, when electrolytes become imbalanced, right, your kidneys can also fail as a result of that. So that is why we ask our patients to hydrate, drink, 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 drink. Especially now that it's so very hot, you have to drink.
Right. Is there any correlation, or is there, or can sickle cell create complications like hypertension and diabetes in a patient?
I don't know. Sometimes you say, chicken and egg, what comes first? Sickle cell disease can affect your heart because when your blood is levels are very low, so the anemia, you can put strain on your heart and make it bigger, and because it's pumping so hard to give your body oxygen, and that in itself can lead to hypertension. But also, just some of these diseases are lifestyle diseases, so without proper nutrition, not eating too much things that are too salty, not for diabetes, eating things that are too much sugar, not having proper nutrition can go hand in hand. So in some instances, not directly related, but it all goes together with proper nutrition, eating healthy, drinking lots of water as well.
So also remember that you can have sickle cell alone, or you can have sickle cell, but you still can have diabetes and hypertension on their own. Okay, because sometimes you think that when you have one disease, it cancels out the others. Remember that people can have more than one. So you can have a child who has sickle cell and has disease. Okay, so God forbid, but those are things that can happen. They don't have to be correlated as doctor says, but they can run concurrently.
Well, this is the reason why I ask, because sometimes you hear of individuals who are ill. So someone may be seriously, they have, for example, they're badly diabetic, really bad, so much so that their kidneys and all of that. And then, but you rarely hear, and I'm speaking here because I don't know, and I expect you to, come in and correct me here. You rarely hear people like that have, let's say, cancer. I don't know if that is correct, but I'm just putting it out. I don't know if it's correct.
You can have both. Uh-huh. You can have both, and I've seen people have both.
They don't cancel each other out.
Yeah.
Okay. But I mean, that's a serious indictment to have. I mean, two conditions like that. I mean, that's like double punishment.
Right. Remember, diabetes and hypertension are psyche and trim.
Right.
Mm-hmm. Right? But you can have the other things that you said it. In the beginning, we did not have our sickle cell patients living as long.
Right.
Now that they live as long, they will get the chronic diseases that come with the elderly, with a more mature life. That can happen. Okay? So think about it. Not only may they have a family propensity to sickle cell and have sickle cell disease, but they can also have a family propensity to diabetes and hypertension. Okay? So you don't really just focus on the sickle cell. You focus on general well-being, especially from childhood. How do you stay well? What do you do to stay well? Whether or not, even if you didn't have sickle cell, you still want to prevent your children from getting hypertension and diabetes as they grow older, high cholesterol. You still want to make sure that your children eat properly, okay? And I'm sorry, I'm having a distraction in my background with some noise that comes on every night. It's really crazy. You want to make sure that the lifestyle your children lead, if you're going to get them to live longer, it doesn't put them at risk for those other diseases that occur in a population that has lived longer. The other thing is that you also want to make sure your children get vaccinated, so they don't have. You don't want to have sickle cell and polio. Okay, you don't want to have sickle cell and have had mumps and have long-standing pneumonias and brain disorder from sickle cell and measles. We keep saying that these are not just. Measles is not just a rash, okay? And so that's why we still promote children having their vaccines, especially the children, as Dr. said, who have compromised immune statuses, right? So you want to make sure that you look holistically at a person with sickle cell disease to make sure that you can prevent as far as possible diseases that are likely to occur as they grow older. Because they're not dying at 15 and 20 anymore. Well, we have had kids who died, and that's something we want to get over as we understand better and we have better facilities. We're going to talk about something that's going to happen soon that should facilitate early intervention in people with sickle cell disease.
Right. I know, Doc, you mentioned earlier about the medication. You mentioned hydroxyurea and so for patients. But someone comes in and they're having a serious, pain crisis. How do you help that individual? I mean, going through that. How do you? And I mean, I can tell you, I've experienced it. Actually, seen someone go through that, and it scared me because it was the very first time I actually experienced that. So it scared me, and it was just scary. But how do you deal with it as a physician? Someone comes to you, in that condition. They need help. They need that pain to go away, or at least to to subside.
Yeah.
So what you do, you start oxygen. So the blood cells are sickling. They're coming together. They're getting stuck. The rest of the body is not. The oxygen carrying capacity is not the greatest. So you start supplemental oxygen to give their body some more oxygen. You start IV fluids. So you start fluids, so you're keeping them hydrated. So in the same thinking, you're getting those blood cells flowing, getting hydration through the body. And then you start pain control. So you try to manage the pain. And then you're doing other things that can also help with the pain. So heat, like a heat pad or a heat rub, those things can help where the sites of the pain, and you're trying to do multiple things at the same time, attacking it from all angles, and just a lot of supporting the person through that very, very painful crisis so the cycle can break and they can get relief. In the background, so all patients that have sickle cell disease, we talked about different types. So the patients that has SS disease or S beta 0 disease, it's recommended now from as early as 9 months, they start the medication hydroxyurea. What hydroxyurea does is increases a type of hemoglobin in your body called fetal hemoglobin. It makes your body make more of those cells and make less of the sickle cells. So it's changing what your body is making. Because at birth, all babies have these fetal hemoglobin. That's why at birth, the patients with sickle cell don't have lots of crises. It's when they start to get older and that fetal hemoglobin is stopped and producing less numbers. So that medication is trying to get the body to go back to that, producing more of that F hemoglobin and less of the S or the sickle one. So doing that and having that on board as a medication daily decreases the chance of the crisis happening even before it happens. So that's why it's important to take that medication. And then as everything we spoke about earlier, the nutrition, all preparing your body before the crisis even starts. So when you do have a crisis, it's not going to last as long, it's not going to be as severe, is the what we want to do. But hydration, oxygen, pain control during the crisis.
Yeah, and I think one of the most important things to attenuate or to minimize that pain that you saw is that patients understand, hey, I'm not so hot, I've not been drinking my water, I've been taking my hydroxyurea last week, because hydroxyurea also helps with the agglutination. It tends to make the cells less sticky, so they can flow a little freer. But then again, if you have fetal hemoglobin, it's going to be a little different. But it tends to decrease the sticking of the cells. If a patient understands, but I think patients' knowledge of the condition. So sometimes the patient knows, I'm going to have pain, and I want to have really bad pain. But you don't necessarily have to have very bad pain if you know that you can stay on your medications. You can keep your fluids. You can do whatever other things. Eat properly, right? So your hemoglobin is up. If you're having a cold, go to the doctor early, right? And of course, just going to the doctor early once you have pain, right? People understand, people who give care understand that sickle cell crises are very, very difficult for the persons who suffer with sickle cell. So you come and say, I'm having pain. Nobody's going to tell you sit on a bench and wait. Well, nobody should tell you to sit on a bench and wait, right? But because it is understood that we cannot need to do early intervention. If the person comes, it's because they understand their crisis and they want to be helped now. So this is an emergency. Let's get going. But I will let Anika talk about the oxygen diffusers because we have some partners that we work with, and recently we were able to get some equipment. We have partners. We have partners in the community like the labs and other community agencies that facilitate our screening, like whoever has health fairs, invites Sickle Cell Association, NULO, the police, the Adventist community, other people who have health fairs and invite us to come and screen for sickle cell. Those are some of the partners. But we also have our international partners, our umbrella organization that covers all of the organizations globally who manage sickle cell and other hemoglobin disorders, and that's called GANSID. I'm going to let Dr. Cloudens just received from GANSID. Talk about GANSID first, and
so GANSID is a global organization that deals with inherited blood disorders, of which sickle cell is a part of, but there are many other inherited blood disorders like thalassemia, for example. So GANSID had this bid where the Sickle Cell Association bid to put on a project, and they help sponsor. So what we are doing is getting oxygen concentrators. We're going to distribute them throughout the island at different health centers. Our aim, we're partnering with GANSID, that I said, but also with the Ministry of Health. Our aim, once we get the oxygen concentrators here and up and running, is to have it at different points of contact throughout Grenada. So patients that have sickle cell disease, and Grenada, Carriacou, and Petit Martinique, yes, who have a crisis can get oxygen started earlier, as soon as possible. So what we're trying to do is to break that sickle cell crisis as soon as possible, to decrease the total length of duration, because there's been some research that shows that early initiation or starting oxygen therapy early can help decrease the length of these painful crises. So that's what's in our pipeline. We're still working on it. We've ordered the equipment. We're waiting for them to get to Grenada, and then we'll continue to partner with Ministry of Health to go to those health centers and get those oxygen concentrators where our patients need them.
And the emergency rooms.
And the emergency rooms, yes.
Okay, wonderful. So, Dr. James, let's talk a little bit about women in particular and sickle cell. Pregnancy and women with sickle cell. Let's talk about this whole thing. While Dr. Nixon has schooled me quite a bit on that, but as chair of the Sickle Cell Association, I think I would trust your word more. Yeah?
Equally.
I'm just teasing, Doc.
I have no feelings.
Yeah.
So, pregnancy. So pregnancy has lots of complications for a person that has never had any medical diagnosis. So even more so with sickle cell disease, because in pregnancy, your blood on a whole gets more sticky because of the hormones, and you're growing a baby. So lots of complications happen because of that. So on top of those complications that can happen with pregnancy without any medical diagnoses, patients with sickle cell disease have just an increased risk So we said that they have anemia, so your blood levels are low to begin with. Now this same blood is needed to keep you alive and healthy, but also to grow a fetus and keep them alive and healthy as well. So that is a complication and a challenge. With sickle cell disease, there's increased risk of stroke, which can be even worsened during pregnancy. There's just poor nutrition on a whole because your blood is not able to carry the nutrition, but now your body is trying to nourish one or two or people. So that's another added strain. You can have heart problems with sickle cell disease. Now that's an extra strain on your heart. So there's just lots of complications. That's why anyone that has sickle cell disease and they're wanting to start a family should reach out to their medical provider very early to learn about all the complication, all the risk involved, checking up on their health status, optimizing themselves with nutrition and medications and things before if planning a pregnancy is something that they're thinking of. But also what's very important, if you have sickle cell disease, there is a higher risk of you passing that on to your child. So knowing what your partner's sickle cell disease status is very important to plan properly as well.
Okay, wonderful.
So we also have to consider the loss of blood that may occur during delivery and how that can affect a mother who's already anemic.
Right.
And the fact that those cells tend to stick. When you're pregnant, the cells get even stickier than they are in the normal season. So if you have sticky cells that get stickier, you have a greater risk for having strokes and embolize, clots in your lungs and other places. So those are the challenges we face. Right? Those are the challenges we face. And our neonatal services may not be as advanced as we'd like them to be. And our post delivery obstetric services does lack some of what exists in the first world. So we probably will ask patients to consider, whether you want to take the risk, because it's a risk everybody will have to take on their own.
Right. But considering all the risks involved, is it, and yes, we spoke of the risk, and of course passing the sickle cell on to the child and all of that. Is it life-threatening, the risks involved? Are these risks life-threatening? Let's say for a mother who, or someone, or a female, who intends to have a child or children, knowing that person is has the sickle cell.
Yeah, so for mothers or intended mothers with sickle cell disease, it can be life-threatening. There are lots of risks that's associated, and a lot of these risks are very serious and can be life-threatening. So that's why it's important to be talking with your medical providers, talking about all the risks, talking about your personal risks. So there's risks that can happen generally, and there's individual risk as well based on your own medical history. So that decision has to be on a case-by-case basis, on a close medical supervision. But these risks can be life-threatening, both to mother and baby.
Right. Would you, as a physician, after seeing a patient and doing your diagnosis, and when you consider everything, could there be situations or a situation as a physician when you would probably recommend that the woman should not get pregnant?
Yes, for sure. As you said, it's case by case, but based on the medical history, complications that this person may have had in the past, and you look at risk-benefit ratio, and there are certain cases where it can be very life-threatening. So they're case-by-case basis. Yes, there are cases where further pregnancy is just too much risk on the mother's body and life-threatening that physicians would recommend not having children.
Okay, wonderful. So let's talk about.
Before you go,
sure.
And I think it follows the general directives that we give to people who plan to have children or who become pregnant. The importance of being seen very early in your pregnancy, especially if you know you have a condition like this. From you miss a period, okay, you want to start seeing the obstetrician, because those are high risk. Somebody with sickle cell is a high risk pregnancy, okay, and it needs to be managed by a specialist. So you can't be going to the doctor when you're 7 months and your belly finally showing and, boy, I feel kind of tired, so let me go and see the doctor and you're lackadaisical about it. That's not how it goes, okay? And I ask all patients to go to your doctor within 2 weeks of, if I miss my period, right? Go to the doctor and get seen, because that is where we are able to contain complications. We're able to guide appropriately, right? And to prevent as far as possible the unfortunate outcomes. You can't wait until you're in labor to turn up at the hospital for a nurse to figure out, to understand that nurse have sickle cell. No, the real one, the bad one. No, and that is where education on our part generally comes in. We try to educate as far as possible, but people also need to seek. My friend, my favorite instrument, the phone, right? Leave TikTok out you can go on TikTok and find about sickle cell, but go and get education. If you heard that your grandfather had sickle cell, go get screened. There are many opportunities so people know early that if I were to become pregnant, right, and let me go to the doctor early. Or if I know that I have sickle cell, I have not been tested, because we test all women, like I said, I plan to get pregnant, I want to get married, I want to have children, or just want to have a baby, I kind of need to make sure that I'm screened properly, because early diagnosis is very, very crucial to good outcomes.
Okay, wonderful. Let's talk generally now about living with sickle cell, and we're talking about full-blown sickle cell here, not just the trait. So let's talk about living with sickle cell, and let's talk a little bit about the work of the Sickle Cell Association, because I'm looking at the clock and I'm realizing the time is just racing. Yeah, it's not sticking at all like sickle cell. It's just going. So let's talk a bit about that.
So living with sickle cell, we talked about lots of complications, but there are many patients doing everything that we talked about, the nutrition, the taking the medication, staying hydrated, can live long, healthy, full lives, can do lots of careers and partake in lots of things, sometimes with limitations and caveats. However, patients and our sickle cell warriors and their families do really good work and follow good instructions to support patients living with sickle cell disease. So we're not trying to put any limitations on patients, but necessarily just helping them so that they can live a full life. So the Sickle Cell Association does a lot of education, so and awareness and raising awareness of sickle cell disease for people to get talking, to start the conversation. So you can think, I've heard that, as Dr. Nixon said, like my grandfather or someone, my aunt, my cousin may have had something, sickle cell disease. I don't know if it's a trait or the full disease, but we're going to get tested. I'm going to get tested. I'm going to get my family tested, so I could know my status. So Sickle Cell Association partners with lots of community partners and different organizations, and we go to health fairs. And we do testing. We have a phlebotomist that comes along with us who's part of the association, and we do blood testing. And then once the results are back, we reach out to everyone to let them know what their results are. So we get testing for patients, for the general population in Grenada, to know their status. Because as Dr. Nixon says, as much as 1 in 15 people have sickle cell trait in Grenada. And I'm sure everyone knows more than 15 people. So in that group of 15 people, 1 or more does have sickle cell trait. So it's very common in Grenada. So it's something that we I don't think we talk enough about, which is why the Sickle Cell Association is doing a lot of education campaigns and trying to go to schools and talking to parents in the PTAs about sickle cell disease. We also want to raise awareness to reduce the stigma. Sickle cell disease is not something contagious. You can't get it from someone. You are born with it, you get it from your parents, but you can't get it from being in contact with someone. Patients with sickle cell disease should be able to be included in daily activities with limitations sometimes, but we don't want our patients and children and to be excluded from schools or excluded from the working environment, and excluded from having jobs. They can be normal, participating members of society, and we just need to support them in different ways, but they can contribute greatly. They're patients, famous people throughout the world, or musicians who play certain sports, who are doctors, lawyers, radio announcers. Like, anyone can have sickle cell disease and fulfill dreams that they have. So what we're trying to do is raise education, raise awareness, give education, support our patients, encourage everyone to support people that they know that have sickle cell disease. So yeah.
Someone is asking, there's a question on our WhatsApp platform. Someone is asking, can sickle cells mutate? And they said, meaning, if you got screen and you got SS, can it change to SD?
So no. So that's a good question. Sickle cell disease cannot change or mutate. So it is what it is. There are different types of sickle cell disease. So there's SS, which is two genes. You need two copies of a gene to have sickle cell disease. So you get one copy that's S, one copy that's S, that's sickle cell SS.
Right.
You can have one copy that's S, one copy that's C, that's sickle cell SC disease, similar symptoms. You can have one copy that's S, one copy that's thalassemia. And together it's still sickle cell disease. There's some old notifications or people saying that, full blown are not so bad, but everything is that you have sickle cell disease, it's sickle cell disease, but it doesn't change. So if you have SS, it doesn't change to SC. It doesn't mutate. The one you have is the one you have.
Okay. What if you have, let's say, a child is born to a mother with sickle cell and a father without sickle cell. So there's no trait, there is nothing, but the mother has it. What are the chances of the child being born sickle cell free?
Full-blown disease?
Or sickle cell free, full blown or sickle cell free. What are the chances?
So if the mom has full sickle cell disease, two copies of the gene, the father has nothing. So no abnormal copies, no trait, just A is the normal. So 2 A's. The child does not have any chance of having full sickle cell disease because they would need a copy from dad as well. However, they're going to have sickle cell trait because the cells that mom is giving is going to be only X because mom doesn't have any A or normal cells to give. So all children will have sickle cell trait.
Oh, okay. So once there is some form of sickle cell, any offspring will definitely have a trait.
Well, if the mother has full blown, if one parent has full blown, any offspring will at least have the trait.
Right. And if let's say the mother has the trait and the father has nothing,
then the only mother has a trait. The mother has a trait and the father has nothing, no trait, no disease. So there's
a 25% chance of just the sickle cell trait.
And then the other chances of having normal without the trait, because mom gives 2 copies, dad has 2 copies, so when you kind of match them up, 25% having the trait and then the 75% without any treat.
Okay, so they're better. That's a better. The chances there are a lot better. Okay.
Yeah.
Excellent indeed. Let's talk a little bit about quickly the family. So someone who has sickle cell, let's say full blown, you're in the family. How does a family sort of get themselves in a position to deal with that, to provide support for that individual? Because once someone isn't well, it doesn't just remain with the individual. I mean, other persons are affected. In some instances, not significantly, but in some cases, significantly. How should the family prepare to deal with situations like that?
So especially if they did not know their trait status before, and this news is coming to as a complete surprise, the best thing to do is education. So arm yourself with knowledge on what sickle cell disease is, what do I look out for, how can I best support the child. So nutrition, hydration, going to their regular clinics. For babies, as we said, from 0 to 5, they need to be on a daily antibiotic to prevent infections. So all of these things, we talked a little earlier that patients are now living longer with sickle cell disease, and it's because of these interventions starting as soon as possible. And just supporting, knowing that this is not a sprint, it's a marathon. It's something that the child will have for the rest of their life. But there's something every day, you learn a little bit more, you support them in the best way you can, you encourage them, you learn to look for the symptoms. So you notice, okay, the eyes are getting a little yellow, maybe the outside is hotter, they're not drinking enough water, so we'll increase the water today. They making sure that they don't miss medication doses, knowing everyone has different triggers. Sometimes a lot of exercise is good, so no exercise is bad, but sometimes too much exercise, if they're overexerting themselves, they can have painful crises. So knowing, okay, they did a lot today, so maybe we'll rest tomorrow. Not that we can't do any sports or we can't do anything, but we need to build in rest periods. If there's like exams and it's a very stressful time, building in rest and increasing hydrations around period of extreme stress or extreme heat. So it's a lifelong journey. Arm yourself with knowledge and education, having good family support, not just immediate family, but extended family as well. And then just continuing working close to the Sickle Cell Association. So every child or an adult that has sickle cell disease, we have clinics monthly in St. George's Health Center, in the clinic in St. George's for the adults, and in Princess Alice. So you can reach out to the Sickle Cell Association if you have or know someone with sickle cell disease and you would like to follow us in clinic, so we can follow you, get you on a good regimen, and just continue to support those families.
Okay, wonderful.
I think also the school environment is very important, that they are very aware, and that so you'd have kids in school, for example, who miss a lot of school because they have crises, or just who have pain. And sometimes the children don't understand, they think they're fabricating a disease and stuff. So education in school and among peers is very, very important. And peers and their parents, because kids go and say, Mary's always sick. She keeps disturbing the class when she gets sick. She doesn't come to class. She can't work in a group. Those things. And it's very important that your peers understand that this is a condition, and the kids who have the support in school do a lot better than the other children who go and have to struggle on their own. Okay,
wonderful. Dr. James, Dr. Nixon, time is gone. I usually, when we're having conversations like that, I wish we can go on, just sharing and learning. But, of course, there is always a next time, because education and information like that has to continue. because there's going to be somebody who missed it. So we continue to do what we can so that the information get out there and people can always arm themselves to improve their wellness. So, Dr. James, 30 seconds, closing remarks.
So I just want to thank you for having us here tonight so we can talk about sickle cell disease week. We have a week of activities. Tomorrow we're going to have a motorcade going around the island just raising awareness. And World Sickle Cell Day is Friday. So people wear red should come up and support, wear red ribbon, red clothing, light up your buildings red if possible, so we can raise awareness for sickle cell disease. Thank you.
Thank you very much, Dr. James. It was a pleasure. Doc?
Well, I'm happy that Dr. James was here tonight to do the pediatric part of it and all the elementary parts of it. Dr. James, thank you for being here, and thank you for taking on the world's leadership. I want to just encourage Grenadians and everybody who's listening to us to just be aware. You know, we all still are brothers keepers, okay? We have to understand. I don't think we would ever understand what it is for a child to be in a painful crisis. But you can understand what it is to help a mother or to buy a bottle of water for a kid who doesn't have water, what it is to give them a ride to the clinic. You know, everybody has a role to play in ensuring that we're all well. Those of you who don't know your status, especially your young men, we do screening free of cost. So once you hear there's a screening somewhere, there's health fair or something, right? Don't be afraid and to come to the booth. Come and ask questions. What we forgot to mention, one of the major complications in men is the issue of priapism, where these blood cells clog up and cause an erection that doesn't go down. And that's a severe emergency because it can disturb the erection in the future. So that's one of the things we have to make sure. So you kind of need to know your status. You kind of need to be able to be right to avoid complications. And like we said, the other reasons why we can live long lives, it's important that all of us together in the health sector, families, friends, and above all, the people who have had sickle cell disease are able to come together and collaborate so that the quality of life that people live is much improved and we can have, like I said, longevity extended despite.
Yeah. Well, Dr. Nixon, thank you so very much. Dr. James, thank you so very much for being here. It's always a pleasure, and we're looking forward to your next appearance on the program, which we hope could possibly be. I would let you off for next week, but very soon, very soon. We're looking forward to have you back. So thanks again, and all the best, Doc. Thank you, and we'll be chatting very soon. So good night, and thanks to all viewers and our listeners.
It's raining. People, please boil your water. It's raining heavy, so water comes not very pretty in the pipe. Please boil the water and take precautions against mosquitoes, because now they have good conditions for proliferating. So please there's still Zika and chikungunya and dengue. So don't forget that.
Yes, indeed. So thank you all very much, folks. Those of you who, if you're outside, please be careful, get home safe on the roads. And until tomorrow evening, all the best. Take good care. Bye-bye.
Cancer.
Measles.